Okay.
Yes.
Hello?
Hello, everybody.
Hello.
Hi. Hi, Julian. Hello, everyone. Agron, did you make it to Milwaukee?
Yes, I am home.
Oh, good.
Yes.
How was the flight?
Good. 2 hours from Fort Myers to Chicago, and my son took me from Chicago to Milwaukee. Now,
Oh, that's not bad.
no, it's temperature is here is 40. In Punta Gorda was 80, so it's half.
Big
That's
difference.
No snow. That's good.
Okay, so here we go. No snow.
Yes. How's Hawaii weather?
Hawaii, it's currently 78. So it's really
Oh,
good, really nice.
Right.
And it's 2:00 here.
oh, it's almost 7 in Wisconsin.
Oh, okay. Hello.
Sarah, do you like those articles that I'm sending you, or
Yeah.
do you want something else?
Nope, they're great.
Okay.
I just we can't do them all, sadly.
Yes,
You have
okay.
to pick and choose here and there.
Okay.
Yeah, no, they're perfect. Keep on sending them. Thank you.
Okay.
Hi, this is Dr. Choshai.
Hello, Dr. Choshai. Thank you for
Hello.
joining us.
Nora, how are you?
I'm doing good. Good. How about you? How is everything over there?
Good, thank you. It's a beautiful sunny day, and tomorrow will snow. Perfect New England weather.
Oh God.
Perfect.
You're
Where
in
are
this,
you, now, where are you now?
I'm in Hawaii.
Excellent. That's where you should be.
Yes, 78 degree. Sun is shining.
Albanians have a word. I hope I say it right. Aratisur. Tipseya aratisur. Why?
Nayemi aratisur moti.
Yeah, that really is true. Oh, Spurt, so nice to hear you. Please forgive me for not having a suit on, but it's 80 degrees outside. And as an old surgeon, the only thing I know about congestive heart failure is my own present case.
Well, it's okay. We just like your presence. We don't
Thank
think
you.
about what you're wearing at all.
Thank you, Jubaim. Thank you. So
Yeah.
who else is on the line here? I see 19 participants. Excellent.
Yeah,
You
we're waiting
know,
for more.
Laura, you have done with what 4 previous presidents, myself included, have not done. You've gotten more than 5 people interested in our society. God bless you, Spurt. God bless you. Shko tutia.
Oh, thank you so much. I appreciate everything you say. That's very nice of you. Coming from you, it's really, yeah, I'm humbled right now.
Oh, but thank you, Spurt.
Yeah.
All
Hi,
right.
Professor.
Who's this?
It's me, Andrei Tluzin. You have another surgeon, a new one that just came in America 1 year almost before, and I'm just trying here to fit on the health system.
What are you-
We keep in touch.
What are you picking up?
What?
What are you doing?
I'm working, you know.
As a surgeon where?
No surgeon in my country, but
Oh.
I need to take the USMLE exams here, step 1, step 2, step 3, and it's a hard work to do.
It is a hard work, my son. Somebody's
Yes, thank
calling.
you. I'm also
not-
listening to you, and I'm
I'm
working
not
for the research part, you know.
You're
As you
looking
advised
for,
me for the research parts, you listen. You said me to make a little bit better my resume for the research part, and I'm trying
Yes.
to also to improve this part. And I'm listening you very nice.
good.
Careful.
Well, I hope that helps.
Okay.
Sadly, as everyone on this line knows, the USMLEs can be a daunting process here,
Yeah.
and it's done intentionally so. So I wish you good luck. I wish you good luck.
Thank you.
In the old days, they used to say to Mount America Premier. I don't know what morning more Premier Kate, but inshallah the Maritira permit to me.
Thank you. I appreciate very much. Yeah. It's a big challenge for me, you know.
It's a big challenge for everybody. I mean, think about it.
Yes.
If you're not an
Yes.
American, you have to come to our country, learn our customs, and
Absolutely.
a language and idiosyncrasies, and you know, it's easier for me as an American to learn Albanian than it is for Albanians to learn American.
Yeah. Yeah, but Albanians speak a lot of languages. They have 36 letters, and almost everywhere they are very nice with languages. They know German, Italian, English, but you Americans don't need other languages. They just need only English. That's it.
Well, but that's true in Germany too. You know, if you look at the young doctors that are practicing in Germany, Aurora Dolenberg, I mean, they had to go through German and speak German and be really get very fluent in it. So it's
Okay.
one of the things you
Das
have.
ist meine Vergnügen, ja.
Yeah.
Wir können auch in Deutsch sprechen.
Awesome. So, Dr. Gashi, do you want to get started with the introduction? I think we've got.
Is that Dr. Sarah Creatino?
That's me. Hi, Dr. Chavushai.
Hi, nice to hear your
Good to
voice.
see you. Thank you for joining us today.
Now I'll be quiet. Dashi, don't be quiet.
No.
Dr.
Okay.
Chosai, the reason why all these journal clubs are happening smoothly, it's because of Sarah Cruzio, by the way. She's amazing.
Thank you, but I definitely know there's a lot of
Yeah.
people involved. Thank you.
I've already done my homework. The people at NYU like her very, very, very much.
Oh,
I'm happy to hear that.
that's
She's
great.
a rising star in American surgery.
Awesome. Amazing.
By the way, can I also greet the colleague that support me and also invite me in this conference, Dr. Kushtrim. He's very nice, doctor, anyone, and Dr. Lindita Choku.
Thank you, Andre.
Oh, yeah, brother. Thank you very much.
Thank you.
Yeah, I just mentioned. Yeah, okay. Thank you for your invitation from your heart. You know, by heart. I'm
Thank you.
thankful for it.
Happy to have you here, man.
Yeah, great.
Now, great meetings start on time and end on time. Let's begin.
All right, so we have all the presenters joined us. Yeah, okay. All right, good evening, everyone. Welcome and thank you for joining us tonight at Albanian American Medical Society Journal Club. I am Nora Gashi, internal medicine hospitalist, currently practicing in Honolulu, Hawaii. I'm a president of Albanian Albanian Medical Society president. We are excited to see so many Albanian medical professionals who are participating in these events and hope to see more join us as we intend to prepare more events like this, grand round seminars and journal club. So tonight's topic is heart failure diagnosis and management, specifically the diabetes medication SGLT2 inhibitors, sodium glucose cotransporter 2 inhibitor on management of heart failure. Presentation by Dr. Kushtrim Salihu, future internal medicine resident at SUNY Downstate, Brooklyn, New York. Then we have article review from New England Journal of Medicine, Dapagliflozin in patients with heart failure and reduced ejection fraction. And this will be presented by Ermelinda Ndoka, first-year medical student at Loyola University, Chicago. And we have our special guest moderators, Dr. Eleonora Gashi, interventional cardiologist, clinical assistant professor at Mount Sinai Health System, and she practices in Manhattan, New York, and Dr. Anton Camaj, cardiology fellow at Mount Sinai Health System. Welcome again, and Kushtrim, you can start the presentation.
Yes, thank you very much, Nora, for introduction. Thank you, everyone, for attending this meeting. Hopefully, we'll do good, and we'll be happy to answer any question that you may have at the end. So, can I share the screen here again?
Yep, you're able to share now. Go ahead.
Jürgen.
Hello.
Yes.
Hi, Jürgen. Nice to see you.
Nice
I
to
see you're still sloppy. Ah.
Okay. Heart failure, diagnosis, and management.
Kushtrim, can you put it in presenter mode? I think we'd be able to see it a little better.
Present what?
Just make it bigger.
Uh,
It's
the
okay.
slide-
Continue. Yep.
The
So-
slides?
No, it's just like to fill the screen, as a present mode.
Kushtrim, there's at the
then-
bottom right, there's one of the buttons right
Yep.
next to the minus sign.
Left.
So go
Left.
left. There you
there.
go, that one.
Oh, I see. Okay, that I
Wow.
didn't know. Thank you. Heart failure, diagnosis, and management. So today's learning objective will be understanding and recognize the different type of heart failure, understand the pathophysiology and symptoms in heart failure, understand and describe management of heart failure, and understand the benefits of SGLT2 inhibitors in the management of heart failure. Heart failure, also known as congestive heart failure, occurs when the heart muscles fail to pump blood sufficiently to meet the requirements of metabolizing tissues. So heart failure is a major cause of mortality, morbidity, and poor quality of life. SGLT2 inhibitors are a new class of drugs demonstrating beneficial effect in heart failure when added to the standard therapy. This is the anatomy of heart with two ventricles, two atriums, and main blood vessels. So we have two types of heart failure: systolic heart failure, which is presented with low ejection fraction, and diastolic heart failure, which presents with preserved ejection fraction. On systolic heart failure, the heart failed to pump the blood outside from the chambers, and this is measured by ejection fraction, which normal should be 55, and in systolic heart failure, ejection fraction is low. Compared to diastolic heart failure, the heart fails to relax and the blood inside the heart is less. So the ejection fraction on diastolic heart failure will be normal. So how is ejection fraction calculated? Is calculated between total volume and stroke volume. Total volume is the volume which heart can handle the blood inside the ventricle, approximately 110 ml, and stroke volume is the volume of blood that will flow outside the ventricle in one contraction, about 70 ml per contraction. When we calculate these numbers, ejection fraction would be around 64, which is normal. Heart failure or systolic heart failure. As you see, total volume here is normal, 110, but the stroke volume is low, 44. And when you calculate, ejection fraction will be 40%, which is low. Compared to diastolic heart failure, as you see here, total volume now is low, 69. On this case, stroke volume is 44, same with the systolic heart failure. And on diastolic heart failure, you see the ejection fraction is 64, which that's why it's called heart failure with preserved ejection fraction. However, the stroke volume is still low, which is heart failure. Pathophysiology. Heart failure is caused by a condition which reduces efficiency of myocardium, leading to overload on myocardium. Over the time, increased workload will produce changes to the heart, like reduced contractility, reduced stroke volume, increased heart rate, hypertrophy of myocardium, and enlargement of ventricles. So this is a slide where you can see a normal heart, pretty uniform ventricle muscles. Compared to a diastolic heart failure, you see very thick myocardium and the room inside the ventricles is less than the normal. This is systolic heart failure, where the muscles are very thin and the room is bigger than in the normal conditions, but the heart still is weak or is not strong enough to pump the blood outside from ventricles. Risk factors. So conditions that leads to heart failure are high blood pressure, coronary artery disease, heart attack, diabetes, congenital heart defects, valvular heart disease, and cardiomyopathies. So what are the symptoms? Because the heart is unable to push the blood forward, the blood will start to build up backward, and it will build up on the lungs, on the legs, and abdomen. On the lungs, it will give congestion or fluid buildup in the lungs. That's why it's called congestive heart failure, because of lung congestion. On the legs, will give peripheral edema, and abdomen will give ascites. As you see symptoms here, again, edema, Oralson, lung examination, ascites, GBD, S3 gallops, orthopnea, paroxysmal nocturnal dyspnea, and fatigue. Complication of heart failure. So the main complication of heart failure are arrhythmias, thromboembolism, hepatic congestion and dysfunction, muscle wasting, and pulmonary congestion. Classification of heart failure. So on this table, you will see both classification from American College of Cardiology Foundation and the New York Heart Association. So I'll describe, they are pretty much similar one to each other, and I'll describe the New York Heart Association classification. Class 1, no limitation of physical activity. Ordinary physical activities does not cause symptoms of heart failure. Class 2, slight limitation of physical activity, comfortable at rest, but ordinary physical activities result in symptoms of heart failure. Class 3, marked limitation on physical activity, comfortable at rest, but less than ordinary activities cause symptoms of heart failure. And class 4, unable to carry on any physical activity without symptoms of heart failure or symptoms of heart failure at rest. So based on this classification, we also have the treatment. So on the treatment, for class 1, first line will be ARNIs. If ARNI intolerant, will give ACE inhibitors. If ARNI and ACE inhibitor intolerant, then we'll use ARBs on top of beta blockers. Class 2 will add spironolactone, ivabradine if heart rate above 70 and patient is taking maximal tolerated dose of beta blockers. If needed, cardiac resynchronization therapy and defibrillator. Class 3, if you have African American patient, you'll use isodyl hydralazine. If still symptomatic, we'll add the digoxin. And class 4, transplant or hospice care. So very important not to use ARNIs together with ACE inhibitors. If you have to switch from ACE inhibitor to ARNI, you have to wait for 36 hours. Sodium glucose cotransporter 2 inhibitors. So SGLT2 inhibitors, also known as gliflozins, are used in treatment of type 2 diabetes mellitus. They decrease reabsorption of glucose in the kidney, lower blood glucose, lower body weight, and blood pressure. Members of gliflozins, canagliflozin, dapagliflozin, and empagliflozin. drug interactions. So mainly they are very safe to use, except if you use combined with loop diuretics and thiazide diuretics will increase diuresis. This is the pathophysiology of sodium glucose transporters and what they do on nephrons. They increase urinary glucose excretion, increase delivery of sodium to the distal tubules, which may influence several physiologic functions like lowering preload, lowering afterload, and downregulation of elevated sympathetic activity. Again, another slide where they how they work, the SGLT2 inhibitors on the kidney. They reduce glucose sodium reabsorption to reduce plasma glucose in circulation, reduce plasma volume and systolic blood pressure, downregulation of elevated sympathetic activity in the heart, reduce preload and afterload. Altogether, very good endpoint for patient with heart failure. This is a slide of a nephrons, and as you see, SGLT, we have two SGLT receptors, type 1 and type 2. So type 2 and type 1 SGLT receptors mainly work on proximal convoluted tubules. If we block the SGLT2 receptors, about 90% of the glucose will remain in the urine and will cause glucosuria. Because of that, we'll have loss of calories, and also sodium will be excreted in urine, will reduce blood pressure. This slide tells us effects and mechanism of SGLT2 receptors. Diuresis and natriuresis. This one we just discussed. Renal hemodynamics. This is very important because the SGLT2 receptors constrict afferent glomerular arterial. This leads to reduction in intraglomerular pressure, and reducing intraglomerular pressure will help kidneys to survive for longer. Myocardial energy metabolism, also very important. They prefer oxidation of ketone bodies versus free fatty acids. And this also is a saving mechanism for the heart metabolism. Indication, Dapagliflozin, also known as Farxiga, is indicated to reduce risk of cardiovascular death, hospitalization of heart failure in adults with heart failure, class 2 to class 4, with reduced ejection fraction. To reduce the risk of hospitalization for heart failure in adults with type 2 diabetes mellitus and established cardiovascular disease or multiple cardiovascular risk factors, as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes mellitus. Contraindication. So if you have previous allergy reaction to Farxiga, if your EGFR is less than 30, or patients are on dialysis, it is not recommended for diabetes mellitus type 1 and diabetic ketoacidosis. Mortality benefits. As you see here on this table, all these drugs, ACE inhibitors, ARBs, beta blockers, mineralocorticoid receptor antagonists, they all have shown mortality benefit on heart failure. On top of these, recently, SGLT2 inhibitors have shown a great benefit on mortality for heart failure patients. So on this side, you can see the percentage of each class and benefit on mortality. And this is a slide where it compares the effect of SGLT2 inhibitor in patients with type 2 diabetes. So there are pros and cons, but as you see, cons are more cons are less than pros. Unfavorable effects: genital infection, mainly mucotic infection due to increased glucose in urine, diabetic ketoacidosis, amputation, and fractures. Favorable effect: prevention of heart failure, prevention of renal function, reduction in major adverse cardiovascular event, reduction in blood pressure, weight loss, and improvement in glycemia. So how we can prevent heart failure? We can prevent by preventing and controlling conditions that cause heart failure, like coronary artery disease, high blood pressure, diabetes, and obesity. These are references. Thank you for the slide. And I just want to introduce for next journal club on May 17th, 8 p.m. present the neurological symptoms and cognitive dysfunction in non-hospitalized COVID-19 long haulers. Present Megina Brate Dervishi, and the moderator will be Ermal Boydani. Thank you.
Excellent.
Good job, Kushtrim. This is Nora Gashi, the other Nora Gashi, I should say, or as I'm introducing myself to this group, Eleonora, which I never go by Eleonora, but now I have to because we have another Nora Gashi. So the name here says Deron Barayo, that's my husband. As soon as I logged the Zoom, I didn't want to change anything, but good job, Kushtrim. And I just wanted to say that, you know, in the field of congestive heart failure, you see all these different medications, beta blockers, ACE, ARNIs, and now we have sodium glucose inhibitors, and none of these drugs were actually devised for the purpose of being tried out on CHF patients. It's just, they've been along for a long time, and along the way, we found out benefits in terms of cardioprotective effects and heart failure. So the same story is happening nowadays, where we have an anti-diabetic drug having some mortality and hospitalization benefits in this subgroup. So I think that's an interesting take in terms of what happens in this particular field. So I'll let Ermelinda continue with the DAPA, and then we'll continue, but I just wanted to add that.
You brought up a good point, which is an important one to consider. First, I'd like to say that that presentation was spectacular. As an old surgeon, I enjoyed it, but I also have my board certification in critical care, so it's something that I do a little bit about. Excellent presentation. You really covered everything. But the benefit is basically a subgroup analysis. And subgroup analysis historically have a hard time of withholding the test of time. Yeah, we're all running out to give everybody these new medications now because theoretically there's this slight survival advantage in subgroup analysis, but be careful with the side effects that the patients may have. I was just speaking to our congestive heart failure group here at Hartford Hospital, and 3 of them love them, and 1 of them doesn't. And who knows what's right. So I just wanted to throw a little historical perspective, plus to say, excellent presentation. I really
Thank you, Dr. Chaush. I really appreciate that.
It kept me awake, which is unusual for a man my age.
Thank you very much.
And I just wanted to add something too, Kushtrim. Nice job. Great slides. Very well put together. I do want to say, Dr. Camaj, it's also nice to meet you. And I know in prior subgroup analyses, these drugs have been shown to be a benefit, but I think pretty soon we'll see a pretty recent blockbuster trial that Ermelinda will present that shows further support for the medication. But I think it's important. Yeah, I think it's important to remember heart failure as a phenotype when you compare ejection fraction. So all these medications that you listed, Kushtrim, have only shown any sort of mortality or survival benefit in patients with a reduced ejection fraction. And by that, I mean an ejection fraction of less than 40%. Classically, we describe preserved ejection fraction as 50% or higher. So that 40 to 50 is kind of that middle range. And that's where you'll get a lot of, stylistic approaches of taking care of these patients.
Especially because it's
but
hard to differentiate between diastolic and systolic congestive heart failure without a reduced ejection fraction.
True, exactly. And also, even in the studies that they've done in patients with preserved ejection fractions, there has been no mortality benefit just in that subgroup of patients alone. So, but it's still important to remember that when you see these patients in the hospital, you're going to be an intern soon, Kushtrim, and for the medical students here, it's still a clinical diagnosis. So patients can come in, you might not know anything about them, but if they're coming in with the symptoms that you highlighted, like shortness of breath, crackles in the lungs, elevated jugular veins, things like that, lower extremity edema, that is a clinical presentation of heart failure. And then you can just, go on to find out, is it preserved ejection fraction reduced, and what's the etiology? Why do they have heart failure in the first place? And then you can do some more digging, but heart failure in and of itself is, you should always remember, it's a clinical presentation, a clinical diagnosis, and then you further stratify patients based on more objective criteria and then treat them accordingly. So
As I said,
nice job.
As I said to Nora, I unfortunately suffer from congestive heart failure and from diabetes, having been a diabetic since age 30. And I can tell you, I feel abdominal distension before I feel any pulmonary symptoms and well before I feel any peripheral edema. If
Wow.
I'm feeling peripheral edema, I'm being hospitalized.
Thanks for sharing that with us.
No, you need for me to meet. Why not?
Yeah.
I'm having scum through
Yeah.
with them everything she just.
I can add something else. I agree to a certain extent with Dr. Chahusha is that how long it will take for this evidence to become reality and practice, because lots of cardiologists do not yet practice this medication in terms of heart failure. They're trying to stay away from that. So it will take some years until this becomes a real practice, until other cardiologists sees what's the true and what's not true. So second is that, can the patient afford it? How the cost effective, how they are. Are we adding more medication to the already polypharmacy? So the reality will show, are these medication in reality and practice good or no? We'll see about that.
That's a good point, actually, because the one thing is, in terms of whenever a medication makes it into guidelines, usually there's a lag in terms of when does it become clinical mainstay, because people are not comfortable. It's a new regimen, new side effects, so it takes time. For example, even with ARNIs, I think, looking at the national numbers, it took about a good 5 years before, majority of hospitals, had that in their formulary, and the patients were taking it, and the insurance was up, paying for it, or even in demographic areas where the insurance was an issue and vouchers were available. So I think on average about 5 years. So since the sodium glucose transporters are so like kind of one of the most recent kid on the block, I think, it's still early for everybody to implement that. But I think, next couple of years, I think we should see the same tagging along with the ARNIs and the rest of the pillars of the CHF treatment. But I'm not surprised, even clinically, I do have internists, a cardiologist starts a sodium glucose transport inhibitor just for the internist to actually discontinue the drug, because under the pretense that you don't have diabetes, why do you have this diabetic medication on board? So there's a multidisciplinary involvement. It's not just cardiology giving it to you, but you have to get in touch with the PMD, with endocrinologists. And I know from the inpatient setting, it just, whenever you have the discussion with everybody, it makes it easier, because it's still not common knowledge. It's still not out there that you have a non-diabetic patient with CHF being given a diabetic anti-glycemic medication. So I completely agree with you. But at least hopefully the trend will be toward the right track, and eventually everybody will be on it if the mortality continues to be prolonged.
And sadly, you realize that to not underestimate the stupidity of the American physician.
I mean, it's just, physicians, are busy, with clinical work, and not everybody can keep up with every guideline that comes out there on a daily basis. So to that defense.
Yeah, you, Kate, I'm sorry.
Yeah.
So just we just have a comment from Igla here, and she's pharmacist.
Yeah.
I would like to hear more about that. She just commented here in group.
Speak up.
Hey, Igla.
Hi everyone. So I guess wanted to let you guys know that these medications are being currently used a good amount, but not necessarily in patients who just have heart failure. They're really just used in patients with diabetes, and especially in patients who have both diagnoses of diabetes and heart failure.
Yeah.
So I practice in Ohio in the outpatient ambulatory care clinics that I've worked in. This is standard practice.
Excellent.
I will say, yeah, it's been slow to pick up, but I do have some patients that I see in my clinic that I've started on it. There's been a hassle of starting patients who are currently hospitalized on the medication, so we usually do start it in an outpatient setting. But it's starting to gain some traction, but again, just like the RNAs or Entresto, I think it'll take some time before people become much more comfortable with them and really finding the appropriate scenarios to put these patients on, because there's so many medications now. It's hard to put someone on like 5 or 6 meds and say, hey, this is all just for your heart, and convince them to take all of those. So there might be situations where this might be a better drug for a patient because of intolerance to other things, or who knows, but I think it'll find a niche, and we are seeing it used more and more, but still very slowly, I think.
I mean, just to piggyback on what Anton was saying, we have these major 4 pillars. We have beta blockers, MRAs, RNAs, and now we have the sodium glucose transport inhibitors. And are we going to just discharge our patients with like a bag full of new pills now, or are we going to have to basically consolidate? I think what Anton was saying, like they have to find a niche. For example, just over the weekend, I started somebody on Entresto, in addition to basically the beta blockers that they were on and spironolactone, and we're like, all right, let's just figure out the Entresto as well. The patient didn't tolerate it, hypotensive, a little bit dizzy, orthostatics are positive. So basically he declared himself that he cannot tolerate Entresto. So we went back to an AAMS, DC the Entresto, make sure that the BP is okay. And maybe patients like that who are not very volume overloaded, the diary is very well, there's room now to add the sodium glucose inhibitor for the mortality and a reduction in hospitalization benefit. So we still don't know exactly, how to basically stack these medications, which one should you add first on or last, but at least, it's an option, and then we can still add it if, like you said, if they won't be able to tolerate the other medications for whatever reasons.
I think we should take it from there and have Ermelinda present to us the recent data on SGLT2 inhibitors.
You go ahead and share my screen.
Hello? We can't hear you.
Can you hear me now?
Yes.
Okay.
Yes, a little bit better.
Okay, I'll just get closer. Okay, so can everybody see it okay?
Yeah, it's perfect. Go ahead. Perfect.
Great. Okay, so hi everyone. Thanks all for coming and letting me present. So I'm Ermelinda, and I'll be discussing the DAPA-HF study looking at dapagliflozin in patients with heart failure and reduced ejection fraction. Although this is kind of from a few years ago now, it has become a study that's pretty important in what treatment has started to entail for heart failure. So just to get us thinking a little bit more about this, I'll touch on some of the background that was there previously before this study. So from previous large clinical studies, the researchers knew that SGLT2 inhibitor drugs such as what Dr. Salihu mentioned, empagliflozin, canagliflozin, and dapagliflozin worked in patients with type 2 diabetes to lower the rate of cardiovascular outcomes, death, and hospitalization. In these type 2 diabetes patients, however, the patients had not previously been diagnosed with heart failure, so the SGLT2 inhibitors prevented the onset of heart failure. In other words, it decreased the risk of first hospitalization for heart failure. So again, as we heard from Dr. Salihu, SGLT2 inhibitors work to block the uptake of glucose in the proximal tubular cell in the kidney, and therefore it stops glucose from being transported to the blood, which leads to more excretion of it in the urine. This will then lead to a decrease in plasma glucose. It can also lead to a decrease in body weight, decrease in blood pressure, decrease in plasma uric acid, and decrease in glomerular filtration rate. Although they have diuretic and hemodynamic actions, there have been some more recent studies that elucidate potential different mechanisms where SGLT2 inhibitors will exert effects in myocardial metabolism, ion transporters, fibrosis, adipokines, and vascular function, but these are also areas of active research. So with the information that the researchers had, they wanted to see for the patients who were diagnosed with heart failure with reduced ejection fraction, whether or not they had diabetes, if SGLT2 inhibitor Dapagliflozin would reduce worsening heart failure or cardiovascular death. So we knew from the previous studies that Dapagliflozin might be good at preventing heart failure, but in this specific study, they wanted to see whether this SGLT2 inhibitor would be a good treatment or a potential good treatment for patients that already had established heart failure with reduced ejection fraction. In the trial, they ended up having 4,744 patients who were randomized from 410 centers in 20 different countries from different varied parts of the world. The trial was randomized, controlled, and double-blind, which means that neither the participants or those who were administering the drugs or the placebo would know who was getting which one. The patients were enrolled from 2017 to 2018 with a median follow-up of 18.2 months. So the patients in the trial were pretty typical of such studies. They had to be 18 or older, have an ejection fraction of less than or equal to 40%. They had a New York Heart Association functional classification of 2 to 4 and an NT-proBNP level of greater than or equal to 600 picograms per milliliter. But if they were hospitalized in the past 12 months for heart failure, this value would need to be over 400 picograms per milliliter, or if they had atrial fibrillation or flutter on baseline ECG, then this number would have to be over 900 for them to be included in the study. And then some people were excluded from the trial, and this was if they had recent treatment with or unacceptable side effects of SGLT2 inhibitors, if they were diagnosed with type 1 diabetes, if they had hypotension or a blood pressure of less than 95. They were also excluded if they had an estimated glomerular filtration rate of less than 30. In addition to the different inclusion and exclusion criteria, the patients were required to receive standard heart failure device therapy, whether that was ICDs, CRTs, or both, and standard drug therapies. And they were encouraged to use mineralocorticoid receptor blockers. Further, they had to use diabetes glucose lowering therapies if they had been prescribed these before. Before getting to their nearly 5,000 subjects, they had a 14-day screening period to decipher which patients matched the inclusion and exclusion criteria. And then patients were randomly assigned following stratification based on diagnosis of type 2 diabetes and were given 10 milligrams of dapagliflozin per day or for the control matching placebo. Dapagliflozin or placebo were to be discontinued if pregnancy or diabetic ketoacidosis occurred. There could be a dose reduction to 5 milligrams or temporary discontinuation. in case acute or unexpected decline in GFR happened or if there was volume depletion. But if this got better, then they could restart it or increase the dose. It's important to note here that in such run-in period study designs, although the results are valid, they have limited generalizability through exclusion of different patient subgroups. So like I mentioned, they can exclude patients that are non-adherent or non-compliant, or those unable to tolerate SGLT inhibitors. So this can lead to overestimation of benefits, such as a lower number needed to treat, or it can underestimate the risk of a medication. So when they were looking at outcomes, the primary outcome they wanted to look at was a composite of worsening heart failure or death from cardiovascular causes. Worsening heart failure was defined as unplanned hospitalization or urgent visit resulting in IV therapy for heart failure. In addition, there were a few secondary outcomes they looked at, including a composite of hospitalization for heart failure or cardiovascular death. They looked at the change from baseline to 8 months in the total symptom score of Kansas City cardiomyopathy questionnaire. This is that's scored on a scale from 0 to 100, where a higher score means fewer symptoms, and a change of 5 or more is recognized as clinically meaningful. The secondary outcome was a composite of worsening renal function, defined as sustained decline in the eGFR of 50% or greater, and end-stage renal disease or renal death. And then lastly, they also looked at death from any cause. So really briefly, to touch on the stats, they used Cox models to calculate hazard ratios, 95% confidence intervals, and two-sided p-values, and they used an intention to treat model, which is based on the initial treatment assignment and not the treatment that a specific patient eventually received. So just to go over the patient characteristics really quickly, we can see that most patients in the trial were white, with few patients in other racial categories, but we can also see that there were similar numbers of patients with and without diabetes that were included in the trial. And then, so just looking at the results, we can see that the incidence of cardiovascular outcomes here, which was a primary outcome, the red line represents the placebo, and you can see that it's higher than the Dapagliflozin line, which is in blue. And this means that the Dapagliflozin group fared better as compared to those who received the placebo. Again, for some of the secondary outcomes, we can see that those in the Dapagliflozin group fared better than those in the placebo group with respect to hospitalization for heart failure and death from different cardiovascular causes. And as if you remember from earlier, the Kansas City cardiomyopathy questionnaire scored on a scale from 0 to 100, where a higher score means fewer symptoms and a change of 5 or more is recognized as clinically meaningful. You can see that at 8 months, the change in this number of Dapagliflozin group was over 5 and almost double that of the placebo group. So based on their analyses, they found that the risk of primary composite outcome was lower in the Dapagliflozin group than in the placebo group, and that the medication was generally equally effective in subgroups. So for example, in the patients that I mentioned before with type 2 diabetes and patients with no diabetes, the treatment was similarly beneficial. this could mean that the treatment has other beneficial actions other than glucose lowering. So then one exception to this, however, was the possible heterogeneity of effect with less treatment benefits in patients with NYHA functional class 3 or 4 than in class 2. So the trial itself had many strengths which have contributed to it becoming so well known. It had distinct population from the patients in previous studies of SGLT2 inhibitors. These patients had a general higher risk of hospitalization from heart failure and for death from cardiovascular causes. Further, serious adverse events were not common and they rarely led to discontinuation. So you can see from the table here that they were similar to, if not lower than those in the placebo group. Even though there were strengths, obviously the study had its limitations. So it had limited generalizability. A lot of it was due to specific inclusion and exclusion criteria, which I mentioned earlier as a flaw of the run-in period study design. In addition, less than 5% of the patients were Black and few were very elderly with coexisting conditions. Another kind of limitation to the study was that baseline use of sacubitril valsartan was lower. So it is more effective than renin-angiotensin system blockade alone at reducing the incidence of heart failure and death from cardiovascular causes. But post hoc subgroup analysis did find that the benefit of dapagliflozin was similar in patients treated with sacubitril valsartan and those who were not. So in conclusion, they did find that in patients with or without diabetes and heart failure with reduced ejection fraction, treatment with dapagliflozin lowered risk of worsening heart failure or death from cardiovascular causes and bettered the symptom scores as compared to those who only received the placebo. So these are some of the sources I used. And I'd like to thank Dr. Cruziu, Dr. Salihu, Dr. Camaj, and Dr. Gashi, and of course, AAMS for letting me present. And then just as a final slide here, I'll let Dr. Camaj and Dr. Gashi take over for how this is implemented clinically.
Good job, Ermelinda. And thank you. So that last slide was pretty much, in terms of the thought process, in terms of what the next step is, how do we implement these drugs? And it was just, we kind of touched base on it before the article was even being presented, that it ideally for the patient safety should be from a multidisciplinary standpoint. You talk to the primary medical doctor, you inform them, talk to the patient so that they know their own story, so that when they go elsewhere and get care in different hospitals, they know what they're being treated for and what the reason is. And I also wanted to add in terms of the previous chart where I was showing the percentage of people on certain medications, at least it's noteworthy than that I don't have the chart right in front of me, but at least 90% of patients are already taking ACE inhibitors. About 90% of patients are also taking beta blockers or not. And that's a pretty good number for national standards of people who tolerate these medications. And then fewer number on MRAs and RNAs, but at least, they're a good regimen that we know that has mortality benefit. So on the background of those certain medications, addition of DAPA actually did have a good outcome in terms of the heart failure, hospitalization, and primary overall outcome. Anton, anything from your standpoint?
Yeah, first of all, really nice job, Ermelinda. Great slides, great presentation, really nice analysis of the study. So nice job with that. I just want to touch on Dr. Gashi's comments. And yeah, but point out that, not over 90% of patients were already on really good therapies, and an overwhelming majority were also pretty low kind of on the symptom scale. So New York Heart Association class 1 or 2. So people who were not very symptomatic to begin with. So chances are very well controlled heart failure. So the addition of these medications on top of already beneficial therapy and people who are pretty well controlled showed a pretty big benefit. It's important, but it also sheds light on a lot of selection bias. And I think you mentioned the run-in period. So when they design these clinical trials, the run-in period is important because it weeds out the people who would otherwise not be good study participants, people who wouldn't tolerate the medication. And so you're really selecting A, for people who are good patients, B, people who can tolerate the drug, and then we already enrolled patients who are already very pretty well controlled to begin with. So it leads us to wonder, first of all, if patients are doing so well, it's one, is it going to be easy to convince them to take another medication? Two, what about those patients who aren't doing so well? Because they weren't very well represented in the study, and the ones who had very severe symptoms, at least in the subgroup analysis here, didn't seem to show much of a benefit or adverse reaction to the drug. So that's a group that's going to need to be looked at a little bit more closely, at least as it pertains to this medication. But all in all, I know the heart failure community was really excited when this paper was published. It gives you another tool in the toolbox to help treat these patients. So, I think the more we have at our disposal, the better. But yeah, I think, the study was great, also flawed for the reasons I mentioned, but I think you did a really nice job of going through, the ins and outs of the study. And I think overall it's a very positive trial for people who have heart failure. So.
Okay, question from my end. At what stage do you consider?
How about a comment?
A comment?
Yeah, where's Ermelinda? That was an absolutely spectacular presentation. And I really enjoyed it. It was well put together. The slides were just spot on. As one of my professors at Hopkins would say, you couldn't have done it any better. And that was just great. And I wanted to say that. No question, nothing else. I'm sorry, but it was fantastic. Now it's all yours, Sarah. I'm sorry.
No, my question's boring compared to that. But given that most of the patients in this trial were stage 1 or 2, I was wondering when do you consider adding the SGLT2 inhibitors to a patient's regimen? Is it later on, or is it early on based on the results of the trial? When do you decide this patient has had too many hospitalizations for heart failure or hasn't had them and decide to add that drug on?
So from my standpoint right now, as I deal with inpatient heart failure patients, patients who come frequently with readmissions within 30 days of discharge, and that number nationally is about 25% of heart failure patients get readmitted within 30 days, so pretty bad number. You add all the medication that we already talked about, but then that would be a good candidate to also add the sodium glucose transport inhibitors. But then again, in terms of the sequence of when you add which one and you take the other one, it depends on a couple of different factors in terms of the blood pressure, how the volume is, how the insurance issues. So it's like a multifactorial assessment of what's the right regimen for this one person. So that's why we cannot just have the same regimen for everybody, the same. And you always start beta blocker or always ACE, because there's so many factors at play. The renal function, basically in terms of the insurance issues and in terms of volume status and a lot of different things. So I can't just give you a cookie cut version of this is how you do it, but it's just you have to discuss it with a lot of people involved.
Yeah, I can give you an example. I have a patient who I met a few months ago. He's a 52-year-old guy, and we diagnosed him with heart failure when he came to the hospital. We started him on a beta blocker and Entresto. He was doing well. I saw him in clinic a few times. He was very stable, feeling better, very asymptomatic. And then I said, hey, look, you're a young guy. There's another medication on the market. I don't think it's going to affect you in a bad way by any means. And I think you could get long-term benefit from it. I'm not sure if you'll feel much better because of it. But I think long-term, you might see some good benefits. And it's really, do they want to take another medication at that point? Sometimes I'll say, hey, doc, I'm feeling pretty good. I don't really want to add another medication, or I don't see why I need to add it. Sometimes I'll say, hey, that sounds great. Minimal side effects. It's one more pill. It's fine. I can do that. And you're telling me maybe it'll add some, keep me out of the hospital or add a few more years on to the end of my life. And those patients who are really sick, then it becomes kind of a matter of kind of juggling what they tolerate and what they can't. And like Dr. Gashi was saying, what's their blood pressure doing? What's their kidney function doing? These are all things we got to pay attention to. So certainly patients in diabetes, you might also want to consider this, even though the study showed that it helps patients with or without diabetes. So.
I think the endocrinologists are pretty eager to use the SGLT2 inhibitor. So I'm not, I don't know how that's interacting with the cardiologists. Like, I'm not sure if you're seeing it used more and more, because I do know that the endocrinologists are preferring to start patients on SGLT2 inhibitors when they can.
That's true. And in my hospital per se, I actually reached out to the endocrinologist just so that we don't run into issues where, like the example that I gave you, like we start a medication and they follow up in a primary medical office, like without any endocrinologist involved, and they stop the medication. So I kind of reached out to her and trying to kind of educate the rest of our staff in the hospital and take it from there so that everybody's on the same page and expects and understands the rationale behind it. So I think it's just, again, keeping everybody informed, the providers and the patient. I think that's the best answer to this whole strategy of polypharmacy in terms of setting of CHF. I kind of wanted to add something in terms of HFpEF that Anton kind of mentioned in terms of where are we going with this medication. Is there room for sodium glucose inhibitors in HFpEF first? So in terms of the mechanism that Kushtrim really eloquently described, the effect of this drug in the proximal tubule of the nephron, like 90% of the glucose is absorbed through that pathway with the sodium glucose inhibitors. But we don't have any of these transporters in the myocardium, actually. So the thought process is, then where's the benefit coming from with the sodium glucose inhibitors in terms of CHF? Are we thinking that is because of natriuresis, you're losing sodium, then you're losing volume, or like you said, reduction in preload and afterload, or is there some other mechanism at play? And if you look at from the transport in the cellular level, we have the sodium glucose exchanger in the proximal tubule, but in the heart, we have these sodium hydrogen exchange transport molecules, which are really working together with a sodium calcium exchange molecule. So we have these two different pumps in the myocardial, in the myocytes. And apparently the inhibitors like DAPA act like ligands on the sodium hydrogen exchange molecule. But what is the outcome? If you're blocking the sodium hydrogen exchange, what you're doing is you're preventing the influx of sodium inward. So if you're preventing the influx of sodium inward, you're also exerting an effect on the sodium calcium pump that's next to it. And therefore you're reducing the gradient for basically calcium influx. And we know that calcium influx, whether it's coming from the sarcoplasmic reticulum versus extracellular, can be cytotoxic and increase apoptosis and so on. So the thought process is, if it's helping in a mechanism that is independent of volume or natriuretic mechanisms, it may have a direct effect on the fibrosis and remodeling of the myocardium in and of itself. And with that in mind, it may have some room to figure out what's going on in HFpEF as well. So maybe we'll see something in the future, but for now, as he said, we don't have any solid data for HFpEF, but at least we have a supposed mechanism that may help out. So stay tuned for another journal club a year from now on DAPA in HFpEF.
How come? Wow, that was fantastic.
Eleonora, I have a question.
Uh-huh.
So as a primary care, these are the medications that I always have a hard time starting. It's like, oh, should I or should I not? If a patient has diabetes, I have no problem starting the medication. But if a patient doesn't have diabetes and I'm starting because I just found out EF was 40%, and what is your recommendation as primary care? Do I contact the cardiologist? They are already on ACE and beta blockers. Do they need to be on Entresto first before we would start something else? So these are the questions that I have and think about it all the time. And I don't have that courage to kind of like start, okay, I'll start you on it. And I think insurance should approve it. So what is your thought with primary care? Like, how should be our approach?
Usually, I would say send them to the cardiologist, not because I would want to give more work to cardiology, because my dad says, Once you go to one doctor, they tell you go to another doctor, and just keep on going and going. So anyway, but I really would think you have to go at least initially to a cardiologist, because you might have to have more frequent monitoring. Sometimes what I see in our clinic, what we do is, all right, we have an Entresto, we have a beta blockers, you have to have close monitored heart rate, but also renal function, the volume status. Sometimes we see them once a week, especially if they're really bad, HFrEFs with frequent hospitalizations. So, with time, I think it's going to become like aspirin, maybe in like a couple of years. But right now, I think since we're also navigating the field and it's new for cardiologists as well, I think nobody would fault anybody for just sending them to cardiologists to actually get the appropriate regimen.
Can I say something as a patient? I have this problem. And what did I do? I don't go to my primary care doctor. I go to a specialist cardiologist in congestive heart failure.
Yeah.
Granted, it's not severe, and they've got me on medications, but you really should consider, what would you do if it were your mother or your father? And for me, I went to the specialist. Sorry, I don't want the primary care doctor deciding whether to put me on Entresto or not. No disrespect.
And I have another question for cardiologists. So in terms of, you mentioned there's something that readmission rate for CHF is 25%. And we have all of this medication and we're adding more. How come?
The compliance issue, the prescription rate is a problem. And dietary non-discretion, a lot of factors, but I think and also depending on what state you're looking at, but this is national average. Because places like New York City, even New York City, a hospital varies from a hospital. Like a hospital in Manhattan is a little bit different from a hospital in the Bronx. So I know I have friends around the Bronx, and basic compliance is completely different. And a patient has to understand why they're taking these drugs, because then they just omit them for no good reason, and then next thing you know, they come to a hospital fully overloaded and within 30 days of discharge. So it's multifactorial, and it just cannot just say one thing or another. So.
I recognized a Greek patient of mine in the congestive heart failure clinic. And I smiled and I said, how are you doing? And he said, how I was doing. And I said, great. I said, one thing I miss is feta. And he said to me, you miss feta? I just have a little piece every day. And he wondered why he was always in the congestive heart failure clinic.
Yeah.
So we have a question in the chat. Richard, do you want to?
Sure. Yeah. Thank you, Sarah.
Go for it. Of course.
Hi, everyone. So my question basically was, it seems from at least the proposed mechanism of action that there's some sort of possible diuretic effect that they're seeing. And I thank you, Dr. Gashi, for elaborating on that other potential mechanism. But wouldn't we benefit from a study that kind of compares another diuretic to these diabetic medications to see if that benefit boost kind of gets erased in the setting of extra diuresis, like in the form of Lasix or in the form of any other diuretic?
I mean, so I don't think a head-to-head comparison with Lasix really would make sense. Kind of we use thiazide for blood pressure control, and they do have some diuretic component. But when a patient comes in fully overloaded, we don't just blast them with hydrochlorothiazide. We blast them with Lasix. Right. So although there's a diuretic glucosuria, I mean natriuresis and volume loss because of that mechanism, it's not we don't think of it as a full diuretic medication, because the intensity is not as severe. So although it reduces the blood pressure and reduces preload and afterload, they're not as strong as a Lasix, and that's more like in terms of reducing congestion, whereas this one is used more for the long-term cardioprotective benefit. And in addition, you kind of get some diuresis from it, but it's not like that's the main goal of it. So we would not start DAPA for diuresis. Does that make sense? Or
yeah, it does make sense.
Yeah. So Richard, just to touch on it, actually diuretics as a class have never been shown to improve survival in patients with heart failure. So they work a little differently, and I think in terms of how SGLT2 inhibitors have cardioprotective benefit, the mechanism of that is still, I think, poorly understood. So I think time will tell. I'm sure we'll figure out eventually. But yeah, so doing a head-to-head, I don't think would make sense, because diuretics have already been shown not to improve survival. But that being said, in this DAPA-HF study, over 90% of the patients I think are close. We're on diuretics as well at baseline. So
But look at where we are
good to be
today.
on it.
I'm writing a book on the medical history of the American presidency. Hopefully it'll be my final book. And Franklin Roosevelt died of congestive heart failure. How did they treat him? Well, he died of a stroke, but what was his main symptoms before he died? He was in CHF. They kept him digoxin and bed rest. That's all they had.
Yeah.
Digoxin and bed rest. And he was negotiating Poland away to the Russians.
Interesting fact.
Well, I thought you'd give
It is very interesting fact.
I see.
You know, they say his wife was running the show for a little while there behind the scenes.
not my ex-wife. You mean Roosevelt's wife? Yeah. Gee, maybe.
Yeah.
That was Wilson. Maybe my ex-wife too. I don't know. Who knows?
I can see Agron in there. I thought I had a chai Rusi. Agron, can you show us your chai? Your cup of tea?
Oh, I would love to see it. Chai Rusi, where is that going?
Wow. Okay, cool. Where's your lemon?
But I would still like to say something that the medical students' presentation tonight was simply outstanding and really world class. I'm proud of you.
You can bring Dory.
So I do have a question. About 2 months ago, I just going in for at the doctor, just a yearly check, and they found a really low pulse. So my pulse is in the 30s. So it's like 34, 36, like when they tested it there. And since then, I've done stress test, echo, every test, and actually just yesterday I did a CAT. And so far, and so in the last 16 months that I've gone to the doctor, my heart function has dropped from like 50 to around 35%. So far, we haven't, or they haven't found like any issues that they are able to see. I mean, I still play sports, still do like hard work, basically, manual labor. And I just wanted to see if you guys had any idea of what it could be, or if it's just like a normal, or it's just a thought that I thought I'd try to see if you guys had any opinions.
Sure. Did you say you had variable heart rate? I kind of missed that 1 second. Was it the heart rate or?
Yeah, so my pulse like is very low. It's in the 34, and actually yesterday, like right before I was about to do a CAT, it was 33, and yeah, after they did the CAT, they didn't find anything there. They said everything was good.
Any thyroid issues?
Nope.
Thyroid hormone is okay? TSH, yeah?
Yeah,
You don't ever feel palpitations? Like palpitations, sometimes you can go tachy, fast or slow. No, you never feel like you have extra beats or?
I do have extra beats. I do have like extra beats. It's not, I do have extra beats as well.
Because I mean, we can talk data, but the question is, I wouldn't expect that you would have any ischemia, and I'm not surprised by the CAF being normal in somebody your age range. I'm just wondering whether you would have something that's called a tachybrady syndrome, where the heart rate goes from being fast to being slow. I don't know if you've had a Holter monitor or, and if the PVC number, the burden of PVCs, because that can sometimes cause cardiomyopathy. You know that number, or you don't know? I mean, I can give you my cell phone. We can talk about it later, so we can look into it, so we don't take everybody else's time. But
okay, yeah. I was gonna say, so I'm the only person here that is not a doctor or anything. Like I just do videos.
Okay, I mean, you have my phone number and email, we can just chat and then I can review some of your stuff and I'm sure Antoni can do the same and then we can kind of regroup and get back to you. Is that okay, Jürgen?
Yeah, absolutely. I mean, I do really appreciate it. I mean, so far, I've seen 3 specialists and all of them haven't been able to find like anything. So I'm just,
Okay.
I figured I'd ask.
Yeah, of course,
Perfect timing.
no problem, just let us know.
Nora, I have one more question, and Anton, maybe you also can answer this. Since we're dealing, I know I'm bringing this up, maybe you guys, it's been like very, hello? Oh.
Yeah, go ahead.
Yeah, so how is heart failure and COVID these days? Like, do you see more patients with heart failure? Do you see more patients with coronary artery disease, or what is it like? It's been a year, so I'm sure you've been getting like patients that are affected from COVID. Can you just like talk a little bit about that?
Yeah, definitely. I mean, even during COVID time, I was reading echoes that particular month, and the amount of what we call right-sided heart failure from the pulmonary involvement was, extreme. Like every single patient almost had RV dilation. Then they started having pulmonary emboli, other issues like that. Now that, we're kind of like beyond first surge and second surge, we're also seeing long-term sequelae of them not coming to follow up, running out of medication. So now hospitalizations are increasing, more frequent. They're like, you kind of have to start from the beginning because they were trying to avoid the hospitals. And it seems like, they're falling off the wagon in terms of overall worsening. It's much harder to bring them back to their dry state because it's been so long that they haven't been coming to the clinics or the hospital, because also there was televisits. A lot of televisits were being done. So that's from the CHF standpoint. And the readmission rate that I looked at one of the hospitals we work with have increased. They've gone to 32% just in October, and pretty much they're going up. Now, in terms of the coronary artery disease and STEMIs, there was this national concern about what's happening with the STEMIs. Where are they? Are we missing cases, or are people just not coming? And it seems like people actually, even if they had the STEMI and severe chest pain, they were trying to do everything possible not to show up to hospitals. And then, we don't have, again, national numbers right now exactly what's going on, but even that has increased. So that's where we are, unfortunately.
What about the post-COVID complications like tachycardia that's been happening more and more? What I'm seeing at the patients right now.
Yeah. So tachycardia for sure. I mean, still myocarditis is a differential as well. Like a few months later, we get myocarditis as well. Like we just see young people with low EF and like, whoa, and then we get cardiac MRIs and see that it was myocarditis. Yeah. So that's pretty much what we're dealing with right now. And I'm going to have to get the call because I'm on call and they keep calling me. So thank you guys. And this was fun. So I hope to get to see you guys again.
Oh, you were fantastic. Please do this again with us.
Thank you, Dr.
Thank you.
Oh,
Thank
you were
you,
just great.
Eleonora.
Great.
Thank you so much.
Faleminderit so much.
Anton, do you have anything to say about COVID and heart failure?
Yeah, so I think I was part of a group where we collaborated with some hospitals, both in New York and Italy. We were able to show that myocardial injury is both common and poor prognostic indicator. So not only was it people coming in with heart problems because of COVID, or having heart problems and COVID, but having both at the same time, or having like an elevated troponin when you came to the COVID infection was another prognostic marker. We showed that people can also have, part of the same group, different or new arrhythmias. They can have new structural abnormalities like wall motion abnormalities, and then obviously myocarditis. And then just like long-standing issues with palpitations that can lead to prolonged problems. So a lot of things that are still in the works. I know we're doing this COVID clinic here in my hospital with the cardiology group. So Sundays we're seeing patients and kind of following up, doing EKGs, doing echoes, doing Holters, things like that. It's part of like an IRB funded project and stuff. So trying to see what the long-term effects are of patients who had some kind of cardiac involvement at the time of their COVID infection, seeing what happens to them down the road. So hopefully more to come, but we do see an association there.
Yeah. Okay, great.
Thanks for having me, guys. It's a lot of fun. It's great to be a part of this.
Okay, well, thank you for
and
us and participating in this. This is really, thank you for your effort. I know you're a busy fellow.
we're all busy, but you just got to prioritize things. So for medical students and anyone else, feel free to reach out. I'm always willing to help
Where are
out
you?
or
One last
elaborate,
question.
whatever the case is.
Anton, where are you?
I'm at Mount Sinai in Manhattan.
Okay. I trained at Columbia. Okay.
Oh, nice.
One question in the chat from Garita, if anyone's up for it. It says, how does nutrition and lifestyle changes affect heart failure with the appropriate medications? And do you give any advice to patients in terms of what to eat?
I can tell you, they do give the patient significant advice in the congestive heart failure. They have registered dietitians, especially in our clinic, which is an inner city, Black, Hispanic. We have people there that try to teach them what to eat. It is not easy. It's like the Greek guy who said, I just eat a little feta. That's not too bad. So there are cultural issues that are involved in this thing as well. But clearly, patient compliance with diets is important.
May I ask a follow-up question? Hello?
Yeah.
Yeah.
Hi, in regards to Gerta's question, Ermelinda, thank you for sharing the article with us. You mentioned that the population was not representative in terms of, let's say, minority or cultural or other determinants of health. This question is more in regards to how a drug makes it from a clinical trial to, let's say, in a national guidelines on how to treat diseases. Hold on just a second. My question is, how do you as a physician determine if this drug is applicable to your patient if your patient is not representative of that study?
So that's a good question. And within heart failure, there was a study several years ago. Which one was it? They looked at a combination of hydralazine and Iserdil. I think it was the AHEFT trial, specifically in Black Americans, and they showed a big benefit for them. That was the first time I think within cardiology that we did like something like that. It's a really good question, and it brings to light a bit major issue in medical research, in that there's a lot of poor representation of different groups of people. So the best we can do is just apply the data that we have to each patient. And so, whether it'll work better for certain groups and not as well for others, I think we don't really know. But what you do, what you think is best, I think in that perspective. But it does make it a little bit challenging.
Thank you.
Okay, well, thank you. Thank you, Anton. Thank you, everyone. Kushtrim, Ermelinda, you guys did a great job.
Magnificent.
Yeah.
Amazing. And yeah, hope to see you soon, next month for sure. We'll send an emails, we'll send the links. We have a very interesting presentation next month. It's gonna be with Dr. Ermal Boydani, psychiatrist at in New York.
He's not going to talk about me, is he?
I'm not sure what's the relation
All right,
with
all right.
Boydani.
All right.
I'm not gonna get there.
Okay.
Maybe he's gonna talk about all of us. You
All
don't
right,
know.
that's okay.
And as usual,
It should be fun. What's
It's gonna
that?
be, yeah, for sure it's gonna be a good presentation, fun presentation. We tend not to talk about mental illnesses, but we have to, because now we have these post-COVID complications, and I encourage everyone to join us next month.
I visited Albania and they told me there were no crazy people there.
Exactly.
All the crazy ones left. Okay.
Exactly. All right. Thank you, everyone.
Thank you very much.
Bye-bye. Good night, everybody.
thank you all.
Good night.
Thank you.